I'm Carla Pecoraro.
I'm Anne Woolfield.
And I'm Mel Akerman, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. This week continues our theme of infections in pregnancy. Today, we're talking about hepatitis B. So, what is hepatitis B?
Hepatitis B is an infection of the liver caused by the double-stranded DNA virus, not surprisingly named hepatitis B virus. It's a huge public health issue with about 2 billion people worldwide having evidence of past or present infection, with almost 300 million people being chronic carriers. The overall prevalence of hepatitis B is reported to be 3.5%, but it does vary depending on the geographic area. Highest prevalence is in the Western Pacific, which is a region that technically includes Australia and New Zealand. Hep B is transmitted through exposure to infectious blood or body fluids. For the majority of adults, the virus is transmitted through sexual intercourse. In areas where the disease is rare, Hep B is more commonly spread through sharing needles or unscreened blood products. But by far, the most common cause of transmission worldwide is through vertical transmission, which is where the infection is transmitted from the infected mother to the baby. Vertical transmission is responsible for about 50% of chronic hepatitis B infections worldwide.
So, what actually happens when a person becomes infected with hepatitis B?
Hepatitis B has an incubation period of about 90 days, meaning it takes about 3 months before a person might notice symptoms. But that incubation period can range from as little as 6 weeks to as long as 6 months. About 50% of patients with Hep B infections will become symptomatic, experiencing prodromal symptoms like a rash, arthralgia, myalgia, arthritis, and the classic features of hepatitis, jaundice, and dark urine. In most adults, the virus is self-limiting, and about 95% of adults will clear the virus on their own in about 2 weeks. But about 1 to 5% of adults will develop chronic Hep B, which is defined as persistent infection beyond 6 months after the initial exposure to the virus. The important thing to know about chronic Hep B is that it is not curable. People with chronic Hep B have the infection for life, and about 40% of these patients will develop complications like cirrhosis, hepatocellular carcinoma, and death. Many patients will require medication to reduce the risk of these complications, and in the majority of cases, this medication is required for life.
I mean, that's not great. But 95% of adults clear the virus, so chances are if you get Hep B, you'll probably clear the infection, right?
Whoa, not so fast. While 95% of adults do clear the infection, there's still a 1% chance that they might get acute liver failure and even die. And the chance of clearing the infection is certainly not that high for children and babies. The younger you are when you get infected with hepatitis B, the more likely you are to develop chronic infection. Of children aged 1 to 5, 30 to 50% will develop chronic infection. And for newborn babies, that rate rises to 90%. 90% of infected neonates will become chronic carriers, which, as we've just said, comes with a high risk of complications like liver cirrhosis, hepatocellular carcinoma, and death.
Given that vertical transmission is the most common cause of hepatitis B in neonates, and the significant impact that chronic hepatitis B can have on a person's life, you can see why it is that we care so much about this infection in pregnancy. Prevention is definitely better than cure, especially with a disease like Hep B, where there is no cure.
So how common is it that a mother in Australia or New Zealand is actually going to be a carrier of Hep B?
The prevalence of Hep B carriage in pregnancy is about 0.5 to 1%, and the vast majority of this is from chronic Hep B. Acute Hep B in pregnancy is pretty rare, occurring in only about 1 in 1,000 pregnancies. Now, there are some patient groups who are more likely to have Hep B infection, and these include sex workers, those who have been incarcerated, IV drug users, and those from the Asia-Pacific region, or also Indigenous Australians and Torres Strait Islanders. Despite the higher prevalence of Hep B in these populations, worldwide antenatal guidelines recommend routine antenatal screening of hepatitis B in all pregnant women.
So when do we screen for hepatitis B?
Antenatal screening for hepatitis B infection should occur routinely as part of antenatal serology, performed either pre-pregnancy or in the first trimester, regardless of whether the woman has been vaccinated or not. Studies in Australia and the US have shown that 30 to 65% of people infected with Hep B actually don't know they have the infection until they get screened. Therefore, it's critical that pregnant women are routinely screened so that we can treat the woman and prevent transmission of the infection to the baby.
In high-risk population groups, Hep B screening might be repeated during pregnancy, and this is usually done at the time of the 28-week bloods. High-risk population groups who warrant repeat screening include those with IV drug use, a sexual partner or household contact with chronic hepatitis B, those who have had more than one sex partner in the previous 6 months, and those who have been evaluated or treated for an STI. In general, patients who are Indigenous or from Southeast Asia don't require additional Hep B screening during pregnancy.
So, how do we screen for hepatitis B?
Now, a lot of people might not know this, but when we screen for hepatitis B, what we actually want to order is triple serology. So that means hepatitis B surface antibody, hepatitis B surface antigen, and hepatitis B C antibody.
Ah, yes. Hepatitis B serology. Now, this can definitely seem tricky at first glance, but once you break it down, it's actually quite easy to understand. So let's start with the Hep B surface antigen. Hepatitis B surface antigen is a protein that is found on the surface of the Hep B virus. When a person is exposed to hepatitis B, they'll test positive for the Hep B surface antigen. In those who recover from an acute infection, the surface antigen goes away and will become undetectable. In those who develop chronic hepatitis B, the surface antigen will persist. The definition of chronic hepatitis B is persistence of the Hep B surface antigen beyond 6 months. And the presence of the Hep B surface antigen indicates that a person has the virus and is infectious.
Next, we have hepatitis B surface antibody. When a person is exposed to Hep B surface antigen, their immune system will develop the Hep B surface antibody. This antibody persists for life and conveys immunity to future reinfection. If you don't have hepatitis B surface antibody, then you're not immune and are at risk of being infected with hepatitis B. Patients without Hep B surface antibody are recommended to have the hepatitis B vaccination. Now, here's the kicker. Hepatitis B surface antibody can develop in response to either hepatitis B infection or hepatitis B vaccination. So if somebody tests positive for Hep B surface antibody, you can't tell immediately whether that person has been previously infected with Hep B or if they've just been vaccinated.
So that brings us to hepatitis B core antibodies. Hepatitis B core antibodies develop in response to infection with Hep B. They don't develop from exposure to the Hep B vaccination. So the presence of the Hep B core antibodies can be helpful to determine whether a patient with Hep B surface antibodies has those from a previous infection or simply due to vaccination. Hep B core antibodies can be either IgG or IgM. IgM antibodies are the first detectable antibodies produced after infection, and the presence of Hep B core IgM antibodies indicates acute recent infection within the last 6 months. After this time, they are replaced with IgG antibodies. Hepatitis B core IgG antibodies will again persist for life. Unlike hepatitis B surface antigen, Hep B core antigens can't be detected on blood tests. This is because the Hep B core antigen is actually only present in the liver and not in the blood.
And then we have the hepatitis B E antigen. Hep B E antigen is a protein produced and detected in the blood in response to actively replicating Hep B virus. It's another marker of acute infectivity, along with the Hep B surface antigen. Hep B E antigen can also be monitored to determine the response to treatment. Anti-Hep B E antibody is produced in response to the Hep B E antigen and is also used to monitor recovery from acute infection.
And finally, we have Hep B viral DNA. Hep B viral DNA detects Hep B viral genetic material in the blood. A positive test indicates actively multiplying virus and that the person is highly contagious. It also indicates a high risk of liver damage. A low Hep B viral DNA indicates that the infection is not contagious or that therapy has been effective.
Okay, so let's do a quick summary of what we've learned so far. Hepatitis B is a double-stranded DNA virus that causes an infection of the liver. It's transmitted through exposure to infected body fluids, such as through sex, blood, and birth. Hep B has an incubation period of 6 weeks to 6 months and presents with viral prodrome symptoms, jaundice, and dark urine. Importantly, some patients may be asymptomatic, and 1% of patients may experience acute liver failure.
While most adults will clear hepatitis B, some go on to develop chronic Hep B, which has increased risks of cirrhosis, hepatocellular carcinoma, and death. The risk of developing chronic hepatitis B infection decreases with age. Babies have a 90% chance of developing chronic infection. Children aged 1 to 5 have a 30 to 50% chance of developing chronic infection, and adults have a 1 to 5% chance of developing chronic Hep B infection.
The prevalence of hepatitis B in pregnancy is 0.5 to 1%. High-risk groups include IV drug users, people who have been incarcerated, those from Southeast Asia, Aboriginal and Torres Strait Islanders, and sex workers. All women should be screened for hepatitis B in pregnancy, with high-risk groups being re-screened at 28 weeks. Women who don't have the hepatitis B surface antibody should be offered the Hep B vaccination, which is safe to administer during pregnancy.
Hep B screening is done with hepatitis B surface antigen, hepatitis B surface antibody, and hepatitis B E antigen. Hep B surface antigen is a protein found on the surface of the virus and indicates current infection and that the patient is contagious. If the acute infection clears, the Hep B surface antigen disappears. If the Hep B surface antigen persists beyond 6 months, the person has chronic hepatitis B.
Hep B surface antibody is produced in response to Hep B surface antigen. It persists for life and indicates immunity to Hep B. Hep B surface antibody is formed in response to previous infection or vaccination.
Hep B core antibody indicates current or previous infection with hepatitis B. Hep B core IgM antibodies are the first antibodies produced after infection and indicate recent infection within 6 months. And hepatitis B core IgG antibodies also persist for life.
Hep B E antigen is produced in response to replicating virus and indicates high infectivity. Hep B viral DNA measures the viral load, with higher quantities indicating higher infectivity and also a higher chance of liver damage. The risk of mother-to-child transmission is increased in the presence of Hep B E antigen and high Hep B viral DNA load.
Okay, so let's talk through how to manage hepatitis B in pregnancy. Let's say we're seeing Sally. Sally is a 25-year-old primate who presents at 14 weeks for her booking visit. You notice that her hepatitis B surface antigen is positive. What should we do now?
Well, the first thing we need to do is explore the history. Did Sally know she has hepatitis B? Does she know how she contracted it? It's most likely that Sally herself obtained hepatitis B through vertical transmission from her mother, and we would expect her to have chronic Hep B. The next thing we need to do is arrange some investigations. There are 2 reasons we do these investigations. The first is to determine the level of infectivity of Sally's Hep B virus, and thus the risk of transmission to the child. And the second reason is to determine the impact of Hep B on Sally's liver. These investigations include Hep B E antigen, anti-Hep B E antibody, and HBV DNA. Women who are positive for Hep B E antigen and have high hepatitis B DNA levels have infants who are at increased risk of post-exposure prophylaxis failure and subsequently developing hepatitis B infection. Investigations to assess for liver damage for Sally include liver function tests and a liver ultrasound. A full sexually transmitted infection screen should also be performed to exclude other infections.
Next, we should refer Sally to a multidisciplinary team. This would typically include infectious diseases and a hepatologist. It's also important that we arrange screening of household contacts, existing children and sex partners, and vaccinate those who are susceptible. Hep B is a notifiable disease, and so the public health authorities will be notified about the infection and can help with contact screening.
We should also discuss the impact of Hep B on the pregnancy and the impact of pregnancy on her hepatitis B. In general, pregnancy doesn't worsen the prognosis of Hep B unless the woman has cirrhosis. For women with Hep B cirrhosis in pregnancy, the risk of fetal growth restriction, preterm birth, stillbirth, and intrauterine infections are notably increased. There's also an increased risk of hepatitis flares, but again, only for those with cirrhosis. The main impact of Hep B on the pregnancy is the risk of vertical transmission. The risk of vertical transmission is highest during labour and birth due to exposure to cervical secretions and maternal blood. In utero transmission is uncommon, but actually can occur in situations such as threatened preterm labour, placental abruption, and invasive diagnostic testing. The two most important predictors of vertical transmission are the Hep B viral load and the presence of the Hep B E antigen. Women with Hep B E antigen have a 70 to 90% risk of transmitting Hep B to their baby, compared with a 10 to 40% risk for women without the Hep B E antigen. Now, of course, this is without post-exposure prophylaxis. Thankfully, with the use of PEP, we can reduce the risk of vertical transmission significantly. Interestingly, high Hep B viral loads have been correlated with an increased risk of intrauterine transmission, and this is thought to play a large role in the failure of immunoprophylaxis, with failure rates up to 10%.
Okay, so Sally understands that she's got chronic hepatitis B and that it increases her risk of liver cirrhosis and hepatocellular carcinoma, but there's also a risk of transmission to the baby. She's been referred to a hepatologist, and the public health authorities have helped her with contact tracing and testing of any household contacts, existing children, and sex partners. Her liver function test and liver ultrasound are normal, and her hepatitis bloods have returned. So Sally is positive for hepatitis B E antigen. She has a viral load of 1,000 units per mil, which she understands increases the risk of her baby getting hepatitis B to 70 to 90%. Sally asks you if there are any medications that she can take to help treat her Hep B during pregnancy and reduce the risk of transmitting the infection to her baby.
Well, fortunately, Sally is in luck. We've made some pretty decent strides in preventing transmission of Hep B, and so Sally does have some treatment options. Now, we just mentioned that Hep B is not curable. So while we can't expect to cure Sally of her Hep B, what we can do is reduce the risk of her complications and reduce the risk of vertical transmission from greater than 90% to less than 5%. To do that, we use an antiviral medication called tenofovir. Tenofovir reduces maternal Hep B viral DNA, reduces the risk of mother-to-child transmission, and reduces the chance of post-exposure prophylaxis failure. It is effective, safe, and has a high barrier to antiviral resistance, which is really important because Sally might need to use this medication again in the future. Now, there are some other drugs used to treat Hep B outside of pregnancy, but tenofovir has the best safety record in pregnancy, which is why it's our drug of choice.
So when should we start Sally on tenofovir?
So, there are two situations where we would prescribe tenofovir. The first is if Sally meets any of the usual indications for hepatitis B viral treatment, which depends on certain lab parameters. And the second is to prevent vertical transmission in high-risk pregnancies. In any adult with hepatitis B, the usual indications for administration of tenofovir include an ALT 2 times the upper limit of normal, Hep B viral DNA greater than 20,000 if the Hep B E antigen is positive, or a Hep B viral DNA greater than 2,000 if the Hep B E antigen is negative. Women who meet this criteria should be prescribed tenofovir at any stage of their pregnancy under the advice of a hepatologist. If Sally doesn't meet this criteria, we should recheck her Hep B viral DNA level at 26 to 28 weeks and commence tenofovir if her viral levels are high. The Hep B viral DNA cutoff level is 200,000 international units per mil, or 2 times 10 to the 6 copies per mil. It's really important to double check whether the lab has reported the viral load in international units per mil or copies per mil, so you don't mix this up.
Okay, so we check Sally's hepatitis B viral DNA level again at 28 weeks, and this time it's 200,000 international units per mil. What should we do now?
So now Sally meets the threshold for treatment in order to reduce the risk of vertical transmission. We should commence Sally on tenofovir and continue this for at least 12 weeks after delivery, with cessation being guided by the hepatologist. If you can't remember these cutoff levels, just refer to the ACID Management of Perinatal Infections guidelines.
Okay, so we've started Sally on tenofovir to reduce the risk of mother-to-child transmission. Do we need to do any other tests during pregnancy? Like, what about bloods or scans?
To recap our investigations in pregnancy, we do Hep B surface antigen, Hep B surface antibody, and Hep B core antibody for antenatal screening. If the Hep B surface antigen is positive, we then order Hep B E antigen and Hep B viral DNA levels to check the risk of transmission to the baby, as well as liver function tests and a liver ultrasound to check the impact of Hep B on the maternal liver. Hep B viral DNA levels are repeated again at 28 weeks to determine whether antiviral therapy should be offered to reduce the risk of vertical transmission. And liver function tests should be repeated every 3 months during pregnancy and monthly for 3 to 6 months postpartum. Serial growth scans are not needed unless the woman has cirrhosis. Hep B does not increase the risk of fetal growth restriction.
So, Sally continues her tenofovir and her 3-monthly LFTs remain stable. We're now at 36 weeks, and Sally wants to know if there's anything she should know about her birth and what can be done to reduce the risk of baby getting Hep B. Specifically, should she be having a caesarean section?
Now, there's no evidence to show that caesarean section reduces the risk of vertical transmission of hepatitis B, and so we don't recommend caesarean section just because someone has Hep B. Sally should be reassured that she can absolutely have a vaginal birth if she wants to. There are some precautions we should take, though, to reduce the risk of Hep B transmission during birth. Obviously, we're going to use gloves and wash our hands. This isn't anything different to what we'd normally do. The big question is whether or not we should avoid a fetal scalp electrode or fetal blood sampling. Now, ideally, if a woman has hepatitis B, you should avoid an FSC or fetal scalp lactate. However, there are some circumstances where this might be a safe option. And that would be in situations where the Hep B E antigen is negative and the Hep B viral load is extremely low.
And what about once the baby is born?
The most important thing we can do to reduce the risk of vertical transmission is how we manage the baby. The principles of neonatal management include active immunization with the hepatitis B vaccination, passive immunization with the hepatitis B immunoglobulin, and serologic testing for post-exposure prophylaxis failure. Neonates should be given the hepatitis B vaccination at birth, 2, 4, and 6 months. A further dose should be given at 12 months if the baby was born under 32 weeks or had a birth weight of less than 1 kilo. In New Zealand, the vaccination schedule is a little bit different. All infants are offered routine Hep B vaccination at birth, 6 weeks, 3 months, and 5 months. Hep B immunoglobulin at a dose of 100 international units intramuscularly should be administered within 12 hours of birth. This prevents mother-to-child transmission in 85 to 90% of cases. It basically works by binding the hepatitis B virus, triggering clearance of it before it has a chance to infect the liver cells. One meta-analysis of clinical trials showed that the relative risk of neonatal hepatitis B infection in those who received the vaccine was 0.28, and that this is further improved to 0.08 when immunoglobulin is combined with the hepatitis B vaccination.
Wow, that sounds pretty effective. But could you translate that to something that normal people could understand?
Me too, please.
Now I have to do this on the spot. Thanks, guys. So, it's essentially like multiplying. So, it's this, relative risk of 0.28 is essentially reduced the risk by 72%, and a relative risk of 0.08 essentially is like reducing the rate by 92%. Yeah.
That makes sense.
Nice.
Evidence and to the rescue.
Yeah, great flex. Quick
Okay.
math.
Yeah. Okay, so Sally has her baby. We managed to avoid any antenatal procedures and she has a spontaneous vaginal birth. Her baby receives the Hep B vaccination and a dose of Hep B immunoglobulin at birth, and Sally commits to the routine vaccination schedule for Hep B. When should we be doing serological testing and what should we order?
Sally's baby should have a blood test for Hep B surface antigen and Hep B surface antibody at 9 to 12 months of life. The point of the Hep B surface antigen is to check whether the PEP was effective at preventing Hep B infection, and the point of the Hep B surface antibody is to check whether the vaccination was effective. Low birth weight or preemie babies under 32 weeks don't respond as well to the Hep B vaccine and should have the Hep B surface antibody checked at 7 months to determine whether they need a booster or not. Alternatively, parents might choose to skip this blood test and give these babies a booster at 12 months anyway. If the Hep B surface antigen is positive, then referral should be made to the paediatric team for management of hepatitis B.
What other things should we consider for Sally in the postpartum period? Is she okay to breastfeed?
Provided that appropriate immunoprophylaxis has been given at birth, breastfeeding by hepatitis B surface antigen positive women has not been shown to increase the rates of perinatal transmission. Breastfeeding is also not contraindicated in women with Hep B receiving tenofovir. Hep B V DNA has been detected in the colostrum of hepatitis B positive mothers. However, there have been no cases of transmission through breast milk for babies who've received the Hep B vaccination and Hep B immunoglobulin.
And in terms of follow-up testing, we should monitor Sally for postpartum hepatitis flares with monthly ALT levels. Sally is at particular risk of postpartum flare once we stop the tenofovir, which is usually around the 12-week mark. So monitoring should continue for about 2 to 3 months once the tenofovir has ceased. Lifelong follow-up should be offered for monitoring of complications such as liver disease and hepatocellular carcinoma. This will typically be done through the patient's hepatologist.
Okay, so let's wrap up this episode with a couple of curly questions on hepatitis B in pregnancy. First, Mel, what should we do if Sally had a high-risk combined first trimester screen and was considering invasive testing like amniocentesis or chorionic villus sampling?
Good question. So there is a theoretical risk of mother-to-child transmission with chorionic villus sampling or amniocentesis, although the research is pretty limited. In general, amniocentesis is thought to be safer than chorionic villus sampling, and so this should definitely be the preferred modality if invasive testing is required. Although it's important to avoid performing the amnio through the placenta. One study quoted a 6.4% risk of transmission with amnio versus a 2.5% risk of transmission without. The risk of transmission is increased in the presence of a high viral load of greater than 10 to the power of 7. Overall, the risk of transmission is still pretty low, but amniocentesis can be considered after discussion of the risks with the woman. Although it's important to remember that combined first trimester screening has a high risk of false positives, and so if a woman is considering invasive testing on the basis of a high-risk combined first trimester screen, we would strongly recommend cell-free DNA testing first.
Interesting. All right, let's say Sally is being looked after by a pregnant midwife, and this pregnant midwife accidentally gets a needle stick injury while taking blood from Sally. This one's for you, Carla. What should we do if a pregnant woman is exposed to hepatitis B in pregnancy?
Oh, I think every pregnant woman's worst nightmare. So the first thing to do is to check the midwife's susceptibility to Hep B by performing Hep B surface antibody. If the Hep B surface antibody is greater than 10 international units per mil, then the patient is immune to Hep B and no further action is required. Big sigh of relief. If the anti-Hep B surface antibody is less than 10 international units per mil, then the patient is susceptible and should receive further treatment. The Hep B vaccination and Hep B immunoglobulin should both be administered within 72 hours of exposure. Ideally, they're given at the same time, but in different thighs. The Hep B vaccination has excellent safety data and has been proven to be safe in pregnancy. Hep B immunoglobulin is also safe and is about 75% effective in preventing maternal Hep B infection. The Hep B surface antigen should be performed at 3 months to determine whether the Hep B vaccination and immunoglobulin were effective in preventing infection. Anti-Hep B surface antibodies should also be performed to determine whether the primary vaccination course was successful at inducing immunity. A negative Hep B surface antigen means Hep B infection was avoided, whereas a positive Hep B surface antigen means the woman has become infected.
Okay, good plan. Another one for you, Mel. So what if the baby misses the Hep B dose at birth?
So ideally that shouldn't happen, but there are quite a few situations where parents might decline the hepatitis B vaccination for their baby at birth. One study shows that the most common reasons for patients declining the Hep B vaccination for their baby include believing that the baby is too young, fear of overloading the baby's immune system, believing that the baby has a low risk of being exposed to hepatitis B, or having a preference for the 2, 4, and 6 month vaccination. If an infant has not received a birth dose within the first 7 days of life, a primary 3-dose course of a Hep B containing combination vaccine should be given during the usual schedule, which in Australia is at 2, 4, and 6 months, and in New Zealand is at 6 weeks, 3 months, and 5 months. Catch-up of the birth dose is not necessary. It would be important to be careful of who the baby is exposed to, though. Only 10% of people with chronic Hep B have actually been diagnosed, meaning that if a person has Hep B, they are more likely to not know that they have it. Preterm babies under 32 weeks or under 2 kilos do not respond as well to the Hep B vaccination and therefore should not miss the vaccination at birth. These babies should also have the efficacy of Hep B vaccination confirmed by measuring their anti-Hep B surface antibody level at 7 months of age, and if the antibody titer is less than 10, a booster dose should be given at 12 months of age. Again, if the parents want to avoid that extra blood test, then they can just go ahead and give a booster dose at 12 months anyway without measuring their antibody titer.
Fantastic. Okay, so let's do one final summary of what we've learned about hepatitis B in pregnancy. Hepatitis B is a double-stranded DNA virus that affects the liver. It's transmitted through exposure to infected body fluids, such as through sex, blood, and birth. And Hep B has an incubation period of 6 weeks to 6 months and presents with a viral prodrome, jaundice, and dark urine. Importantly, some patients may be asymptomatic, and 1% of patients may experience acute liver failure.
While most adults will clear hepatitis B, about 1 to 5% go on to develop chronic Hep B, which has a 40% risk of cirrhosis, hepatocellular carcinoma, and death. In babies, the risk of developing chronic Hep B is much higher at 90%.
The prevalence of hepatitis B in pregnancy is 0.5 to 1%. All women should be screened for hepatitis B in pregnancy, with high-risk groups being re-screened at 28 weeks. Hepatitis B screening is done with hepatitis B surface antibody, hepatitis B surface antigen, and hepatitis B core antigen.
Hep B surface antigen indicates current infection and that the patient is contagious. Persistence of the Hep B surface antigen beyond 6 months indicates chronic infection. Hep B surface antibody is produced in response to the Hep B surface antigen and indicates either a previous infection or exposure to vaccination. People who have less than 10 Hep B surface antibody are not immune to Hep B and should be vaccinated. Vaccination is safe in pregnancy. Hep B core antigen or antibody indicates exposure to the Hep B infection rather than vaccination.
Management of Hep B in pregnancy involves referral to a multidisciplinary team, including hepatology and infectious diseases, investigations to assess the impact of hepatitis B on the liver, including LFTs and liver ultrasounds, with LFTs being performed each trimester, and investigations to assess the risk of transmission to the baby, including Hep B E antigen and Hep B viral DNA, which should be repeated at 28 weeks. We should also discuss the impact of pregnancy on hepatitis B, which is minimal, and discuss the impact of hepatitis B on pregnancy, which is mainly vertical transmission.
The risk of vertical transmission is increased in the presence of hepatitis B antigens and high viral load, and this can be as high as 90%. The risk of transmission can be reduced through safe antenatal care practices like avoiding invasive diagnostic testing or fetal blood sampling, through the use of tenofovir, and through administration of the Hep B vaccination and Hep B immunoglobulin at birth.
Usual indications for tenofovir include an ALT 2 times the upper limit of normal, a Hep B viral DNA greater than 20,000 if the Hep B E antigen is positive, or Hep B viral DNA greater than 2,000 if the Hep B E antigen is negative. Additional indications for prevention of mother-to-child transmission in pregnancy include a Hep B viral DNA greater than 200,000 international units per mil, or 2 times 10 to the 6 copies per mil at 26 to 28 weeks. With high viral loads, tenofovir should be commenced by 28 weeks, and stopping tenofovir may be associated with flares, and so LFTs should be monitored monthly for 3 to 6 months after birth.
Caesarean section is not required to reduce the risk of mother-to-child transmission, but fetal blood sampling and fetal scalp electrodes should be avoided. Babies should receive active immunisation with the Hep B vaccination at birth, 2, 4, and 6 months, passive immunisation with the Hep B immunoglobulin within 12 hours of birth, and serologic testing for PEP failure. Hep B surface antibody and Hep B surface antigen should be performed at 9 months. For low birth weight babies or preemies under 32 weeks, Hep B surface antibodies should be checked at 7 months to see if a booster dose is needed, or alternatively, you can skip that test and a booster dose can be given at 12 months.
Postnatally, mum should be monitored with monthly LFTs for the risk of a hepatitis flare. This monitoring should continue for 2 to 3 months after stopping tenofovir, which is usually stopped at 12 weeks in conjunction with a hepatologist. Breastfeeding should be encouraged and does not increase the risk of infection to the baby.
Okay, so I don't know how we've gone through this entire episode without a single fun fact. Surely someone has one before we go.
Of course we do. Mel, what have you got?
Okay, so did you know that Hep B was only discovered in 1965 and was actually originally called the Australia antigen because it was named for an Australian Aboriginal's blood sample that reacted with an antibody in the serum of an American haemophilia patient? Secondly, blood banks only started screening blood donations for Hep B in 1971, meaning that before then, many people were contracting hepatitis B from blood transfusions. And thirdly, some people don't respond to the Hep B vaccination. If you're a non-responder, you should receive 3 additional doses of the Hep B vaccination 1 month apart. If you still don't seroconvert, then you might need intradermal doses. And if you still don't seroconvert after that, then you're probably not protected against Hep B and should really minimize potential exposure. And finally, you absolutely cannot get hepatitis B from the Hep B vaccine. These vaccines are synthetically prepared and do not contain any blood products from Hep B positive people.
Mel, you never fail to amaze me. I loved all of the facts. Thank you very much. And thanks to you for listening to this week's episode of the Uterine Sound. You'll find our summary slides on Instagram later in the week. Unfortunately, Instagram has changed their formatting to rectangles instead of squares, which has completely ruined our beautiful aesthetic. But I'm sure you get the gist anyway. Check out our website, www.theuterinesound.com, email us at theuterinesound@gmail.com, and find us on socials at The Uterine Sound. Until next time, Hepatitis, be right back with our next episode on toxoplasmosis.